We're going to go ahead and move on and to a slightly different arena where low-impact laparoscopy and the technology surrounding it has played a role, and that's with Dr. Kathy Wong, who is hailing from NYU, and she's a minimally invasive gynecologic surgeon who will be sharing her perspectives as she utilizes this on the robotics platform.
Thank you. So we started this conversation, I think, a year and a half ago, maybe 2 years ago now. And there's a lot of data out there going from 15, this is the slide, right? Sorry. Going from 15 to 10, when you decrease your intra-abdominal pressure by a third, you see significantly less pain. A lot of times it's less shoulder pain. But I was a little skeptical whether or not I could operate at a pressure of 10. So we first started operating at pressure of 12. So we looked backwards. We obviously already conventionally operate with a pressure of 15, and then we switched to AirSeal operating at pressure of 12, and then after 100 patients, we went to pressure of 10. So I'm just gonna share with you some of the data that we gathered, and part of it obviously is to see if we can have less pain with the patients, and initially, I was actually trying to do this to see if we can further decrease the recovery time. So I usually send my patients home the same day. 86% of our patients go home the same day after robotic surgery. Average recovery time is about 5 hours, a little more, 5 to 5.5 hours. And then now we have 92% going home on the same day. So oftentimes the people do end up staying. If we finish surgery at 6 or 7, we're not going to tell the patients to go home immediately. So I can't even see that. I can't even see it. It's so far away. So first of all, this is just a demographic slide. So everyone, just so you know, the patients are the same. So it's 100 patients in the 15 millimeter group and 100, so 300 patients in a year and a half. And now you see that their blood loss is increased in the low pressure group, but it was 50 versus 40. That was a median blood loss. So although it's statistically significant, it was not clinically significant. It didn't really result in any increase in blood transfusion. I think we've only transfused 2 so far in the past 3 years. In the surgery time, there was literature previously published talking about if you operate at a lower pressure, you have increased blood loss. So 1, we wanted to see that, and 2, we wanted to look at surgery time because we've also been reported that the surgery time is longer. And we also saw no difference across the board. So our median skin-to-skin time was 80 minutes. And then it's recovery time. So this is actually my primary outcome, which turned out to be the same. It's essentially a little over 5 hours. What we did see, which is not shared here, is that phase 1 to phase 2 time, the phase 1 time did decrease. So even though the overall time did not decrease, they were spending less time in phase 1. And the other thing is, right after we started this protocol, this is not, we obviously started operating at lower pressure, but we also instituted an entire enhanced recovery protocol. We initially started at pressure of 12, and now we're at pressure of 10. And I had PACU nurses coming up to me asking me to implement it for everybody else in the hospital. So we're doing that. And the other thing that we wanted to make sure is that we're not pushing the patients out. So we also got the patient satisfaction surveys, and we did that for 12 months. And there was actually increased satisfaction on the patient part and the nurse's part. And you guys know that it's really important to keep our nurses happy. So also setting the expectation in the hospital, when you see them in the office. I really can't see very well. Okay, so the pain score, you can see that the pain score is lower when you compare 10 to 15 and 12 to 15. So if you're like me and you're a little bit skeptical whether or not you can operate at 10, at least that's how I reacted the first time, go to 12 and see how you feel, see whether or not there's a difference in visualization. We'll have a clip of the video later. But also last year when we did live surgery, we actually operated at the pressure of 10 the whole time, and we just didn't tell the audience. And at the end of the procedure, we asked the audience, did you even realize that did you have any trouble seeing during this procedure? And then no one said yes. And then we told them that we were actually operating at a pressure of 10, so that was helpful to us. So this pain score at T1 is essentially when the patient first got to the recovery room. And then pain max is the maximum pain score that they reported. The last pain score is before they leave the recovery room, and NYU's protocol is that you can't discharge the patient unless the pain score is under 4. So there's going to be no difference in that pain score, which is what we expected. Just to show you, just because previously in the table, you'll see that it's 7 and 7. Because at least I was wondering, why is it the same number? What does that even mean? That distribution of the pain score is different, even if the median number is the same. Okay, so this is the max pain, and this again is the last pain score. So once we establish that we can do this, and this is feasible, and it didn't actually translate into any adverse outcome, didn't translate into increased blood loss, did not increase our operative time, certainly increase the satisfaction of our patients and our nurses, we wanted to look at the respiratory parameters as well. Sorry, I forgot about this one. So if you look at the 10 millimeter group, there's 24 patients that had no analgesic whatsoever during their PACU stay, which was a huge surprise to me. So they didn't even get Tylenol or Toradol. I mean, that's, to me, is huge. So narcotic abuse is a really important issue right now. So we then looked at the respiratory parameters. So I do robotic surgery basically all the time. I don't do any laparoscopy anymore. We do about 90 a quarter, and I ask for maximum Trudell number 100% of the time. I would ask my anesthesiologist for bed limit all the time. So that obviously creates a problem, especially in obese patients. So we wanted to see whether if we're operating at lower pressure, hopefully that should improve their ventilatory efforts. Does that make sense? I'm asking them to give me maximum Trudell number. I got to give them something back, right? It has to be a team, right? It has a team effort, so what are you going to give back? So we looked at the peak inspiratory pressure at T0, sorry, that's baseline. So we just intubated the patient. So just so you know that across the board, it's the same. There are no difference in these 3 groups of patients. T1 is right after insufflation when patients are in Trudell after the trocars are placed. So I do the same thing as you guys. We do place the trocar at 15, or actually sometimes even 20, just to make sure that you're not tracking your trocars. You want your trocars to go in at a 90-degree angle, because if you don't, you're going to increase your risk of herniation, 1, and 2, there's going to be more pain because the robot only moves around the remote center. So if you're tracking your instruments, then 1, you're going to increase the pain, and 2, you may end up with herniation. So T1 is that after insufflation, after we're docked, we haven't started the procedure, and you can see that there's a decrease in peak inspiratory pressure already. And my anesthesiologist will tell me immediately. They just can't wait until I put the pressure to 10. They're like, thank God, when is it going to go to 10? T2 is missed surgery, so if I'm operating for 80 minutes, they're going to, basically T2 will be at 40-minute mark, which is where we figure we will find the max of peak inspiratory pressure. Again, you can see the p-value is less than 0.001. I mean, that's very significant. So, and then we look at the plateau pressure also. That's the pressure that they apply to keep the small airways open. Again, it's different, not that surprising. And then we looked at tidal volume. Again, the tidal volume is also decreased. The PEEP was not different. The lung capacity didn't show any difference. So the reason that we looked at all these different parameters is because we had a long discussion with the anesthesiologist, because I don't really know what's important to them, because I'm not really looking at their monitor. I don't know what parameters are more important to them. So this is after. So I'm very thankful for my anesthesia department. And the last one is end-tidal CO2. That is also lower. So across the board, one, I think the most important thing is actually feasible, and it didn't cause any issues. So if it's doable, it didn't increase your OR time, it didn't increase your blood loss, now can we make it better for the patient? If you operate at a lower pressure, you're going to have less desiccation of your peritoneal tissue, right? So they should have less pain. In our entire enhanced recovery protocol, we also added some other stuff, such as we would actually give them Toradol before they wake up, unless they have a contraindication, obviously. But we also give them Sofran interrupt. So the whole goal is to prevent the nausea and vomiting and the pain before they get to the PACU. So you kind of pre-medicate them intra-op, so that when the patients are in the PACU, they're doing well and your nurses are happy. Okay, I think that is the end of my talk. Thank you. Oh no, this is my video. Sorry, just a few more seconds. So Can you guys see so on the bottom, that's a conventional insufflator at 15. So I do robotic surgery, so the one on the bottom is actually the SI, and everybody who's using the SI and the XI, at least in my experience, the XI is so much smokier, right? It's just, I can't see as well because of the 8mm camera. It just seems to be a lot smokier with the system. So you can see on the top, that is 10 that's the 10, pressure of 10 with the XI, and the bottom is SI, which I will actually see better, but I don't without the AirSeal system.
Okay, well, thank you for sharing with us your recent experience and data regarding the implementation of AirSeal in your robotic surgeries.